And now we will continue the epilepsy and the elderly. Dr. Hassan will give us a lecture about epilepsy and dementia, the bidirectional. And after the lecture of Dr. Hassan, we will discuss very challenging cases between MS, epilepsy. I think Dr. Hassan.
Okay, thank you, Dr. Amin. I'll be brief. I'll be discussing, obviously, I'm continuing Dr. Tricia about the dementia. Probably I'll be discussing, obviously, the elderly population. So my talk will be a combination of dementia and how epileptic patients will get dementia compared to the normal population. And the other, if you get dementia, will you get seizures, epilepsy or not? So the first thing is that in the literature, we need large population studies. We don't have a large population studies. Most of the studies are small numbers. This is one of the things. So the topic will be dementia leading to epilepsy. We all know that dementia is a neurodegenerative disease, and whether they develop seizures, it's a part of the neurodegenerative process. And epileptic patients will get dementia how early or development, depending on how long do they live. So epilepsy leading to dementia, we'll look at the duration of the epileptic attacks. If you get frequent seizures, obviously, of course, if you get convulsive status epileptics, you're going to get an insult to the brain. Anti-seizure medications, number and dose, drug load, which is a concept we should consider when you're adding medications on polytherapy. You should consider the drug loads, the drug load. This is important. And as also the other thing is then the elderly population, as Professor Tricia told you, that they need a lower medications. So if the patient has a long-standing epilepsy, he gets older, probably will need a lower dose, and you have to check the blood levels to rule out the possibility of a drug encephalopathy. And of course, this topic, Dr. William Gihard knows it very well, onset in children, what we call epileptic encephalopathies, a combination of epilepsy and cognitive impairment and encephalopathy. So this is a separate topic for the pediatric epileptologists. And this is the etiology of the epilepsy in the elderly. Mostly, of course, are vascular strokes. You have, of course, we have to rule out the autoimmune causes of epilepsy. We have to, the neurodegenerative conditions, mostly is Alzheimer and traumatic epilepsies, but mostly it's a vascular and traumatic, of course. So if you look at epilepsy and memory disorders, it's bidirectional. Dementia leading to epilepsy and neurodegenerative diseases. Late onset epilepsy, infrequent. Usually the late onset epilepsy is infrequent. You don't find like the younger population, seizures, daily seizures or twice a week. Usually it's infrequent, but still they develop epilepsy compared to the normal. So this is important to consider. It's not a matter just of seizure frequency compared to the younger population. So the aging brain definitely plays a role. Comorbidities, vascular, lipid, diabetes, this is very important because if you control such factors and you choose the right anti-seizure medication, you can lower the incidence of the progressive dementia, and I'll show you another study. Biomarkers is an issue important. EEG ambulatory, whether you do in dementia patients, you do long-term EEG, okay, or ambulatory EEG, and you will discover EEG abnormalities, and whether we should look at, of course, epilepsy or seizures in the elderly in the demented patients is not that easy to recognize because of the clinical scenario. But still, if you do prolonged or ambulatory EEGs, you can pick up EEG abnormalities or what we call subclinical seizures, and if you give the anti-seizure medication, it might alter the progression of the dementia. The issue is whether you get seizures in what age will you develop dementia, younger or later on, and the issue of seizures, whether early stages of dementia or late stages of dementia. Of course, the misdiagnosis is very important and to recognize seizures in this population. And we should also think of the impact of epilepsy on the course of dementia. So this is the relative risks for developing dementia, and as you can see, in the Alzheimer's is around 7.5, and this is, of course, brain tumors, severe traumatic brain injury, hemorrhagic strokes, subarachnoid hemorrhage have highest, but still it's 7.5 the relative risk to having the epilepsy if you have Alzheimer's dementia. And this is cases you should recognize. This is confusions and some myoclonic jerks. As you can tell, of course, what's this? It's a subacute dementia with electrophysiological abnormalities on the EEG and myoclonic jerks. Of course, this is Creutzfeldt disease, and you rule out this. You see it, it's not that rare. You see cases. So it's depression, agitation, apathy, mood swings, rapidly worsening confusion, difficulty in walking, muscle stiffness, twitches, involuntary jerky movements, subacute dementias, and epilepsy or myoclonic jerks. You should think of this diagnosis. Professor Trincia mentioned antibody-mediated epilepsy. If you have focal seizures, psychiatric issues. So this is important. If the patient doesn't, usually in the elderly population, if you get a seizure, the post-ictal confusion can be prolonged. But still, if the patient doesn't improve after some time, you should consider other etiologies like autoimmune epilepsy. So this is the duration of seizure, focal onset, mostly LG1, and psychiatric deficits. So this is also another case, a patient who's confused, okay, and getting seizures. And this is, we listened this morning about the status epilepticus, altered mental status, and this is her EEG. As you can see, it's sharp wave complexes all over. This is a case of non-convulsive status epilepticus, and you should consider this in the elderly population. Non-convulsive can be missed if you don't do a EEG. And the etiology of the non-convulsive status epilepticus, this is after normalization, you still can find further frontal intermittent rhythmic delta activity, and the patient has improved. And this is what you see in the flare. We all know about the flare images, periventricular hyperintensity denoting leukoencephalopathy, and acute subcortical foci. This is what the fasciculus store, we're all aware of this, especially the vascular neurologists. And this is also, you should ask for susceptibility weighted imaging showing bilateral cerebral, cortical, and subcortical microhemorrhages, what we call cerebral microbleeds, and usually find them at the posterior hemisphere. So the etiology of the non-convulsive status epilepticus probably was this. And this cerebral microbleeds, you can find it, as you get older, you get more cerebral microbleeds, you get more tau proteins, you get more amyloid deposition. So the issue is that this vascular pathology with the degenerative process is contributing to both the dementia and the epilepsy. So this is the initial investigations: MRI leukoariosis, severe fasciculus 3, and EEG shows recurrent runs of further with left-sided predominance. Acute cerebral microbleeds can also present with convulsive status epilepticus, and this is a report of 2 cases. And cerebral microbleeds are chronic accumulation of small blood products in the brain tissue with the brain magnetic susceptibility weighted images, SW1. All the stroke patients, of course, you know about this, the SW1. And it increases significantly. It has become a great interest and importance to certain conditions, dementia and stroke, as well as normal aging. So in dementia and epilepsy, Alzheimer's disease and epilepsy are common nervous system diseases in the older adults. The incidence tend to increase with increasing age. In patients older than 65 years, neurodegenerative conditions account for 10% of epilepsy in the elderly. Epilepsy and seizure can occur early or late stages of Alzheimer's disease, leading to functional deterioration or behavior alterations. Diagnosing seizures in the elderly, of course, I won't go into this into detail, but you don't find the GTC, genetic convulsions, except 1/3 of epilepsies in the elderly happen during sleep, nocturnal seizures. So this is very important to consider. But usually during wakefulness, this is what you see: the altered status, confusion, and you can't really tell whether this is related to aging or this is related to dementia the patient has. Other etiologies, of course, to rule out, like as you can see, the syncope, transient glomal amnesia, and transient focal neurological deficits. So seizures can be mistaken for a progression of dementia. So you should consider this when the patient is getting worse with the dementia, provided you have to rule out other things like dehydration, like metabolic disturbances. So this is different population studies. This one study, the highest was in the younger patient group. Another study, it was the later stages of Alzheimer. And the differential findings could partially explain by the difference of population. The true incidence of epilepsy of patients with dementia is likely underestimated because the difficulty in diagnosis and the subtle presentation of some seizure types. So this is an article about from the epilepsy and neurodegeneration, a bidirectional relationship. So we have two studies. We have the fragment study showing that patients with epilepsy can get dementia, and the opposite. It's twofold. And the other study is the atherosclerosis risk in community study. So this is the fragment study. This is a bidirectional association between epilepsy and dementia, either condition carrying a nearly twofold risk of developing the other when compared to controls. So you should consider this important information. This is the other thing, is that patients with late onset epilepsy and without late onset epilepsy, and you can see the progression, of course, of the dementia in patients with late onset epilepsy. This is also 13 years after also. So actually the pathology between epilepsy, vascular disease, and dementia, on one hand, you find the vascular pathologies like obesity, the risk factors, dyslipidemia, small vessel disease, stroke, coronary heart disease, and I said like cerebral microbleeds, which is under-recognized. On the other hand, you can find the amyloid plaques, tau tangles. So there is a combination of vascular risk factors, Alzheimer pathology, and epilepsy. Sometimes you have, I think it's important because it tells you how to manage it. This elderly population has comorbidities. So they were comparing 3 diseases. They were comparing epilepsy and migraine, it's from the biobank in the UK, and strokes. So the incidence of dementia was highest with the epilepsy compared to strokes and compared to migraine. So this is important. And what's more important is that if you look at the triggers, like if you control the factors like abnormal lipid profile, hypertension, diabetes, it improves a lot, and then it doesn't deteriorate the dementia compared to others, the other diseases like stroke or migraine. So the association of dementia risk with focal epilepsy and modifiable cardiovascular factors. So the study found out that epilepsy was associated with significant risk of developing dementia, which was magnified substantially by cardiovascular risk. So epilepsy in the elderly, you should really consider the triggering, most of they have diabetes, they have hypertension, So you have to control these factors, the lipid profile, not to develop dementia, because there's a high risk of developing dementia in epilepsy in the elderly. And if you're looking at drugs, if you compare lacosamide or carbamazepine, it's clear that lacosamide doesn't affect the lipid profile compared to the old generation anti-seizure medication like the carbamazepine. So this is one of the tips. Also, you should choose the right anti-seizure medication in the elderly population. This is about the EEG. The EEG is an issue in looking at EEG abnormalities in patients with Alzheimer's disease, and whether if you have an EEG abnormality, this is ambulatory EEGs, and you can focus on the EEG abnormalities, it might slow the progress of the dementia. So this is epileptic activity is frequently associated with Alzheimer's disease. The association has therapeutic implications because epileptic activity can occur early in the disease and might contribute to the pathogenesis. Of course, there are mouse models, but I'm not sure still about the clinical practice if we could do ambulatory EEGs for patients with Alzheimer, and you should deviate our thinking, looking at a different way of preventing the progression of the disease. So this is an association of EEG abnormality. They were looking at two populations or three populations: 43 cognitively normal healthy adults, 41 patients with early Alzheimer's disease with no history or risk factors for epilepsy, so Alzheimer and epilepsy, and 15 participants with early stage Alzheimer's disease and late onset epilepsy related to Alzheimer's disease. So this is, you have to be in, the EEG abnormalities are not that simple to analyze and to get information about the significance of the EEG abnormality, this ambulatory EEGs. So the epileptiform abnormalities were seen in half the patients with Alzheimer's disease and epilepsy, 22% of Alzheimer with no epilepsy, and 4% of the healthy control. Epilepsy in the elderly in general, the yield is quite low if you do a routine 30-minute recording. So these cases are ambulatory, so they found more abnormalities. So EEG abnormalities, its specific features, epileptiform, high frequency, robust morphology, right temporal location, occurrence during wakefulness and REM, associated with clinical seizures in Alzheimer. It's a bit complicated, but at least it hints about if you find an EEG abnormality with ambulatory, you won't find it on the routine EEG. It might help your way of thinking or giving another treatment compared to the other medications we give. So epileptiform abnormalities are common in Alzheimer, but not all are equivalent. Specific features, epileptiform associated with clinical seizures in Alzheimer's disease. Given the difficulty of recognizing clinical seizures in Alzheimer's disease, these EEG features could provide guidance on which patients with Alzheimer at a higher risk for clinical seizures. And this is another paper about, it's a small number, but looking at the use of levetiracetam in small doses in improving executive functions of patients with dementia. Small numbers, but just gives you, maybe we can change our way of thinking. Investigations of levetiracetam in Alzheimer's disease, at least stabilization of memory functions or good tolerability, improvements in attention and verbal fluency. The dose was quite small. It was 500 to 1,000, but mostly 500, I believe. So this is what we found. This was a placebo crossover with levetiracetam. And they found that levetiracetam effect did not significantly modify cognitive functions, but it improved the executive functions and spatial memory among participants with Alzheimer's disease who had seizures with subclinical epileptiform activity. So this is just a point to tell you that we might think of looking at subclinical epileptiform abnormalities and giving small doses of levetiracetam. It's a small number, study with small numbers, but just it makes one think about the treatment. So dementia patients who suffer from seizures decline faster and die younger than people with dementia who don't have seizures, according to a multi-center study. So the conclusions are epilepsy and dementia is a bidirectional relationship. Clinical manifestations of dementia with epilepsy are different from the younger populations, except if it happens during sleep, generalized tonic-clonic seizures. Diagnosis is challenging. Seizures are infrequent and respond well to low doses of anti-seizure medication. The question is, does the aging brain with dementia and epilepsy have a poorer prognosis than dementia patients without epilepsy? Non-convulsive status epilepticus in the elderly is under-diagnosed. Should we treat subclinical seizures and epileptiform discharges if you do an ambulatory EEG? A natural history of epilepsy in the elderly is not known. Understanding the mechanisms underlying epilepsy in neurodegenerative diseases. Other risk factors should be controlled in dementia patients with epilepsy. And this is important. If you find comorbidities, you have to control the various vascular risk factors like hypertension, diabetes, and abnormal lipid profile. And thank you.
I have a question, please. Yeah. By the way, you spoke about the interictal or the epileptiform discharges in patients with Alzheimer's disease. My question about the deleterious effect of spikes and sharp waves on cognition. This is a different entity. Do you think, is there any rule for using anti-seizure medications for those discharges in patients with cognitive impairment, irrespective of Alzheimer or anything else?
So you mean about the younger population?
Yeah, I'm speaking about the younger population and the deleterious effect of the epileptiform discharge on cognition.
I think one of the studies by Colin Binney in the UK, he always talked about how to kill the spikes. It's chasing EEG. The other thing, if you look at patients with the benign Rolandic seizures, whether you should also kill the spike, I'm not sure about the answer, because there are some EEG abnormalities are age-related. So I'm not sure about whether you should. Exactly, yes.